Now, in addition to these types of knee pains, you can also have just basic arthritis. And all arthritis is a softening or wearing down of the chondral or cartilage surface of the joint. As I mentioned before, here is your bone, the yellow is bone and blue is cartilage. When this cartilage starts to soften, sometimes it will fissure, meaning it will split. Sometimes there will be pieces or little flaps that detach. And sometimes it will actually wear away and little flecks of cartilage will actually be found in the joint. Depending on the size of the defect or the size of the involvement determines the treatment. Most chondral lesions or arthritic symptoms, if they're mild, can be treated with anti-inflammatories and modifying activities. We usually recommend low-impact activities, like things like swimming, biking, elliptical, and staying away from high-impact activities to avoid further damage to the chondral surface or the cartilage. Now, in patients that are very active and let's say have isolated lesions, meaning pinpoint lesions throughout these areas, not diffuse, and it's important to make the distinction. There are many patients who have diffuse arthritis, meaning they have wearing down of the cartilage all throughout that joint, on both sides of the joint, here, underneath the kneecap. Those patients usually are better treated with options such as injections, like steroid injections, therapy, or even viscosupplementation, which are lubricant injections for the joint, which can help with pain and inflammation. And eventually, if the arthritis is bad enough, may need either a partial or a total knee replacement. In younger patients that have isolated lesions, where there is cartilage wear, or where there's cartilage missing, or where there is cartilage that's unstable, there are different options. One option is where we actually identify the cartilage lesion arthroscopically, which means that we put a camera in the knee through a poke hole here, a poke hole there. We use the camera to see where this lesion is, and once we identify the lesion, depending on the size of that lesion, we'll determine the treatment. If it's smaller than 2 centimeters or so, many times we can treat that with what's called a chondroplasty, where we smooth down the cartilage edges, and maybe a microfracture. We actually drill small holes into that area that's bare and allow a little area of bleeding in that area, which will solidify almost like a scab and create fibrocartilage, which is like cartilage, and actually help with that knee pain in that area. That will give you a stable covering. If you think of that as almost like filling in a pothole. So that actually can help. Now that works well with small lesions. If it's a larger lesion, then you have to weigh different options. One option would be an OATS transfer, where we actually use the patient's own cartilage. We take a plug of cartilage from out on the peripheral area here that is not in the weight-bearing area of the joint. This is an area that you do not use when you're walking or you're bending your knee. We just take some small plugs from this area and we actually move them to the area that has the defect. The benefits of that is that it's your own tissue, it's your own bone, and it may have better incorporation because it's your own cells that we're replanting in that defect. If it's a very large lesion, sometimes what we'll do is we'll take a little biopsy of cartilage, we'll send it off, get more cartilage cells produced, and actually go back a second time, find the defect, and actually implant your cartilage cells in that defect. That's called autologous chondrocyte implantation, also known as ACI. And that can help in regards to covering these larger defects. If it's much larger and covers the whole condyle, there are other options such as using an allograft, meaning a cadaver cartilage, where we actually resurface this area with a cadaver cartilage. Or you can use options such as metal resurfacing on those chondral lesions. This here is a picture of certain areas of the joint. For instance, this here is patellofemoral, the kneecap here. We remove the kneecap. This is the trochlea, the groove. This is arthritis. There is options where we actually, if there's large enough amount of arthritis like this really doesn't fall into any of those categories. It may fall into an autologous chondrocyte implantation option, but another option is where we actually remove the arthritic portion of the joint We actually remove the arthritic portion and we place an implant within that groove to give the trochlea a smooth surface. So the kneecap now can actually track within a smooth surface in the joint. Now, the indications for this are very rare, but the patient has to have a well-balanced knee. They have to have arthritis only on one side unless you plan to resurface the kneecap as well. And basically the patient should have failed all conservative measures. Now the other option is a partial replacement, or replacement of just this inner aspect or outer aspect of the knee, where you actually do a resurfacing of that inner aspect here, where you remove the arthritis and you place an implant here. Once again, restoring the contour of the condyle, giving your body a smooth surface. But to do this by itself, you have to make sure you do not have arthritis on the other side. If you do have arthritis on the other side, this tends to be a more difficult, the results aren't as good. You can resurface this portion over here with using a plastic polyethylene plug, but at the same time, if you do have a significant arthritis in this compartment, sometimes the best option is a realignment procedure where we actually unload this joint by realigning this tibia, which obviously is a more invasive procedure, but we actually do, it's called a high tibial osteotomy. We make a cut across the tibia here and actually straighten out the joint, which actually unloads this compartment. That's only in severe cases of severe arthritis involving the inner aspect of the joint in young patients. Otherwise, these resurfacing options or arthroscopic options that we talked about are better options. Another option is a partial replacement, where instead of just removing the areas that are arthritic, you remove the whole inner aspect of the joint and replace this inner aspect here with a condylar implant here, as well as a tibial implant here. And the great thing about these implants is that the joint here, this is the concave portion of the joint, is mobile. So meaning when you extend and flex, this little plastic portion here will actually move with the joint. It's a mobile implant, which means that there's less wear on that implant. So these implants actually last a good time, a good period of time. So those are some basic ideas of what consists of knee pain in general. There are many other possibilities and pathologies within the knee, but more often than not, anterior knee pain, medial knee pain, lateral knee pain, or arthritic pain can all be differentiated, particularly if you go see an orthopedic surgeon and maybe you get some standard x-rays to look at the joint space and undergo a basic physical exam. Occasionally MRI is also indicated to confirm whether or not there is cartilage or ligamentous injury. However, that is up to your orthopedic surgeon's recommendations. So if you have any further questions, you may visit my website at www.jmichaelbennett.com, or feel free to call my office at 281-633-8600, and we'd be happy to schedule an appointment with you. Thank you.